Finally figured out how to get it onto the gallery view so I could see all of my friends on this call. Welcome, everybody. And I thought I would just get sort of the general business out of the way first. Everyone can hear me? Just someone nod their head because I got this AirPod in.
Yeah.
Okay. Just to mention again, last year, Federation distributed $1.5 million locally and $680,000 overseas, if I'm reading all the cards right. And that's between general and designated gifts. And this speaks to our community's generosity and commitment. And I just wanted to say again, it's even though everyone may contribute to things individually and think, why do they have to give through the Federation? It's very powerful when a Federation can make these large, impactful allocations collectively. I wanted to also remind everyone that Aaron mentioned if you say yes on the chat, you can start your pledge so that I don't have to call all of you. Not that I mind calling people, but it would certainly make things easier. And I also wanted to bring up, Jerry has sent out a very nice summary of tax issues as we get towards the end of the year. But it is time to think about those, to think many people are lucky enough to have appreciated stock. I know that I personally have changed to giving appreciated stock to my donor advised fund every 2 to 3 years and take the default the default amount on the other years and then give from my donor advised fund. So if anyone wants to get more information about that, I'm sure any of us, certainly Jerry, Aaron, or me can talk to you about that, but it really is the right thing to do, an intelligent thing to do. And I know all of you are intelligent. Lastly, I also wanted to, maybe it'll come up again, but mention the mission to Israel that we're planning. It started as a bike-focused mission, but there's going to be plenty of opportunity for non-bikers to participate. It's going to be great places to stay, great food, great friends, a little bit of an emphasis on outdoorsness, whether it's biking or hiking. And we're ready to take people on as we're ready to take money. So I know some of you on this call are already committed to the mission. It's going to be, let's see, I wrote it down here. It's March 23rd to April 2nd, COVID and security willing. So it's going to be great. And one of the aspects of that is going to be the dedication of an ambucycle, honoring the founding of Maimonides and our Mickey Upberg, who passed away, unfortunately, recently, that we're all sad about, but we're celebrating him. And we're celebrating the founding of Maimonides. Although this is a health-related transportation vehicle, and we're going to get more details about it, this is not the first time that our Jewish community has gotten together to dedicate and donate a medical transportation item. We're in the coming months about a hearse that was converted into a medical transport system. And apparently this vehicle is still around and is in storage somewhere. And it's a great story. Larry knows something about it. We'll go more into it. We'll leave that hanging for the next brunch. So without further ado, hopefully everyone's seen that list. We're going to get back to that list of founding members. and we're going to have some speakers. But first, Larry, fortunately we have this to talk about, so we don't have to hear a Larry joke, although we do like the Larry Levitt jokes. And we're going to hear a little bit about why the location of the founding meetings were at the Ufberg basement instead of the Levitt basement. Take it away, Larry.
Thank you very much, Billy. What an opportunity to get up in the morning and look forward to a celebration just starting now of the 35th anniversary of the Maimonides Society, for which I think everyone on this call should feel very good and very proud. And specifically, it began in Mickey and Eileen's basement and alternated between their basement and our basement. But I think they preferred Mickey's basement because Eileen's cooking was so well recognized. So Eileen, thank you for that. And many of us, including Bob Gordon, with whom I spoke yesterday, who was one of the first people, remembered the food that you provided to a standing room only crowd in your basement, which was the highlight speaker was Milton Alter, who's no longer alive, but spoke about Jewish genetic diseases. In any case, we indeed have been around for 35 years, and we should feel very good about the fact that this first Maimonides Society in America was duplicated in dozens of cities, where many other cities have tried to do some good for their community. But it started in two basements, Mickey and Eileen's primarily. Also feel good about the fact that 5 years ago, our Maimonides Society donated an ambucycle, which if you'd like to read more about but bring tissues with you, look at the TED Talk by Eli Beers, B-E-E-R-S, who was the inventor of the ambucycle and was a paramedic. And the ambucycle not only saves lives daily, including people getting up from Shabbat meals and getting on their ambucycle with no halachic problem, but it's now being exported to other countries. But you might want to listen to that. And Jerry, you'll correct me, but I think Eli Beers will be our guest speaker at the 35th anniversary celebration, which will take place in January, either live or by Zoom. Also, let's feel good about the fact that there was, before this COVID thing that you may have heard about, an ongoing relationship with Nahariya Hospital, which includes a library, which I think was dedicated to Mickey. I know he donated a lot of books and journals, etc. And we're going to see that on our trip. And also we had guests from Nahariya Hospital every year, one or two, who circulated among the hospitals here and came to many of our houses for dinner. So that's a little bit of the background. Again, I also hope that many of us will join together on the 23rd of March for a spectacular visit to Israel. And finally, I want to make a special shout out and give credit to some guy named Billy Markson, who you may have heard of, but who has done a lot to refresh interest in the Maimonides Society. And most important, he's drawn new members who are younger than the rest of us and will keep this going for a long time. I saw Ufberg family members on this Zoom call, and I hope they feel particularly good about what their dad or their husband, in Eileen's case, did to get this whole thing started, and which continues to this day. Finally, Aaron has been wonderful in facilitating a lot of this stuff. And as Billy said, it's going to hang out there. But we have just Friday discovered that the first vehicle, which was a hearse that became an ambucycle, has been discovered in one of the warehouses in Allentown, Pennsylvania. And the executive director of the Heritage Society will make it available for us at our celebration of our 35th anniversary, which perhaps will take place at the JCC or remotely. So thanks for allowing me to participate in this special event.
Thank you, Larry. And I see Dr. Brooks is here, so we're gonna pass it to him. I'm gonna put the slide of the founding members because he's joining us over the phone. Charlie, you want to take it over?
I'm going to also
Charlie,
I'm going to also, can you hear me?
Can you hear me all right, Aaron?
I can hear.
Oh, good.
Charlie, otherwise known as CB, early joined Mickey, and we're hoping that Charlie talks a little bit about GI and his experience with.
Can you hear me all right, Bill?
Charlie, we hear you very well. Go ahead.
Well, firstly, thank you for this opportunity to honor Mickey's memory to the Maimonides Society. As you know, he is one of the founding members. I first encountered Mickey actually through an ad in the New England Journal of Medicine, which was an anonymous ad, but my wife, Ellie, immediately made the connection to Mickey's brother-in-law, Leon, whom she knew indirectly from Northeast Philadelphia. I think Ellie's aunt lived next to Leon when they were both pre-teenagers. And as soon as Ellie saw the name of Leon's brother-in-law, she immediately made the connection. And then one thing led to another. When I first arrived in Allentown, you know, the practice was interesting in that it's not like it was, like it is today. We had two receptionists who actually answered the phone if someone were to call. We had a small office, and our records were manila folders, as some of you may remember. And our recording equipment was a rather large handheld machine that would record onto tapes, which were then picked up by our typists every night and converted into hard copy. And we somehow struggle along with that for however long it was. The practice was also very active and difficult. We covered 5 hospitals downtown, and I often look back and wonder how we could have possibly done that. In particular, on Tuesday mornings, for example, we would start in Lehighton and do 1 or 2 colonoscopies, and then pick up our stuff, carry it ourselves to the next destination, which was Palmerton. And we would do 2 or 3 colonoscopies in Palmerton before picking up our stuff and taking off for the Lehigh Valley. And we had a very definite plan when we first arrived in the valley. First, we would go to Bethlehem. We were on staff at St. Luke's Bethlehem. And then we would work our way back north and east. So the next stop would be at what is now Lehigh Valley, Muhlenberg, for 1 or 2 patients. And then to Sacred Heart Hospital, and then to the old Allentown Hospital, and then to Lehigh Valley Cedar Crest, which of course was called ASH back in those days. And we used to joke that, you know, as soon as we left one place to the next place, there'd be a bleeder in the previous place. And looking back to that, I'm just surprised that just 2 of us could do that on a regular basis. But that's what practice was like initially, of course, long before all of the advances since then. You know, it's interesting. I've noticed, you know, we all attend funerals and memorial services of various sorts. And what comes up in every single one of them is that the deceased was a great family man and loved his family. And sometimes I'm a little perplexed by that, because we all are predisposed to people who are close to us genetically. It's just an evolutionary trait that we all favor people who are like us in one way or another. But I think the real measure of a person is what he does for others, what he does in addition for his genetically close family members is what he does for others. And Mickey, I think, is unparalleled in that particular regard. When I first arrived in Allentown, actually, I lived in his basement for 3 weeks because my house wasn't ready yet. And the accommodations were great, I must say. They were terrific. They were cleaned daily, probably by me, and Eileen's food was excellent. But I did live in Mickey's house for 3 weeks, and to a large degree, he taught me colonoscopy because colonoscopy was just beyond its infancy, and I hadn't done enough cases yet. And he spent his Thursdays, his day off, teaching me colonoscopy. He also helped me a lot in converting, you know, my mental state from fellowship. I had a fairly easy fellowship, as many fellowships are, but then I arrived in the Lehigh Valley to face that kind of practice, which as you know, I described a bit earlier, was hectic, a little bit disorganized, and very active. And we would cover all 5 of these sites at night as well as during the day, and we were each on every other night. And he did help me a lot in terms of getting accustomed to that kind of lifestyle, which of course is quite different from the average fellowship in gastroenterology. For this, Mickey paid me $37,000, which was very generous by those standards back then. And then he gave me a Hanukkah bonus, which I don't think I deserved for any reason, but he was very generous with me from a financial point of view as well. And our kids became very friendly. Our children, who matched up very nicely with Mickey's and Eileen's children, became friends, and their friendships last to this day. There are still interactions among them that have lasted for 45 years. In spite of all of this, in spite of his community activities, and in spite of being on call every other night, he never asked me for help. He never asked me to cover something for him so he could do something for Federation. And I actually kept waiting for him to ask me, but he held down his half of the work in addition to all of his major responsibilities which he had around the community. And you all know what those were. His major responsibilities in the Jewish community are well known to everybody, but he was also very important in the gastroenterological community. He was chief of gastroenterology for many years, and he conducted himself in that situation very well, was able to be objective about any issue that may arise, and he was a widely heralded chief of gastroenterology, I think for at least 10 years. Also, when Allentown and Sacred Heart got together to form ASH back in the old days, they wanted him to be chief of the medical staff of the new combined hospital, but he just felt there was absolutely too much to do everything he was doing and be chief of the medical staff. But they certainly wanted him because his opinion was always sought in everything. He was a leader in the medical community. Certainly at our breakfast meetings, his opinions counted for a lot. And even in our poker club, for example, his opinions seemed to count more than anyone else's because of his intelligence, his insight, and all of his personal qualities. It's very interesting also, you know, sometimes people are lauded by saying he's a man ahead of his time. Well, you know, to a certain degree, Mickey was a little bit behind his time because he did things and he wanted things that no one else did. He was widely loved by his staff in the office, which was demonstrated in any number of ways. He would make house calls after hours. A house call, for those of you who aren't familiar with the concept, is when the doctor goes to the patient's house for whatever reason, either because the patient is sick or because has no transportation, and takes care of the patient in his house. I should say his or her house. And there's no billing for that. He did it voluntarily with no billing after hours and without a GPS, by the way, to figure out where he was going. He did his own laparoscopy back in those days. He learned also in the house, you know, the house calls, that since not every house had a CAT scanner. It became inefficient after a while to do house calls, but he was committed to this for many years, and he did it in late afternoon and early evening hours. He did his own laparoscopies, which would be almost unheard of today for a gastroenterologist to be trained in laparoscopy. And he would also do some internal medicine as well. In patients who had abdominal pain that was due to functional problems or due to musculoskeletal problems, for example, he would do local injections of the anterior abdominal wall with steroids and lidocaine, often being very helpful for the patients. And his commitment to our patients was unparalleled and resisted in the sense of being before his time. We must have been the last practice in Allentown to allow an automated phone answering system, because he insisted up to the end that he would not allow any patient to call us and be answered by a machine. And as far as I knew, he was the very last holdout on that until it became essentially impossible to continue doing that. And then there was a matter of his Sunday appointments. Mickey wanted to do colonoscopies for free on people who had no insurance, but he realized there was a barrier to that, the barrier being the embarrassment of the person calling in for an appointment. So firstly, we put an ad in the morning call, which we paid for ourselves, incidentally, because the morning call would not publish it for free, inviting Sunday appointments. Please call us and ask for a Sunday appointment. And when a patient called and asked for a Sunday appointment, they were told, okay, your Sunday appointment is on Thursday at 1 o'clock. And as a result of this, we would do colonoscopies at no charge to the patient. And my recollection is Mickey even convinced whoever our pathologist was to not charge for pathologic examination of the specimen. This went on for several years, and maybe it was interesting that there was a lot of commentary in the community, and people asking me in particular what our angle was. What could our angle possibly be to work for free? And the answer is there was no angle. It was just Mickey being Mickey. And I tried to explain this to people. It was simply Mickey being Mickey, doing what he wanted to do for the larger community, regardless of race, religion, or any other consideration. And that went on for quite some time as a total voluntary effort on his part. Even after he no longer was a partner in the practice and was working as an employee, he was fully committed to the patients and the practice. Often we would ask him to stay late to take care of something that had come up, when again, there was no particular specific benefit to him, except to the degree that he was committed to his patients and his practice. And it really is for all of these things that he's made the mark that he has in the Jewish community and in the larger community, and for which he would be remembered for a long time. Thank you for this. This is very important.
Charlie, what wonderful words you have shared with everybody. I think everybody's eyes are a little clouded right now, but we are part of the Maimonides Society, and it would be a disservice to our society if we didn't do a little learning. And so I'm going to pass the ball to Dr. Fred Seltzer, who's going to actually, Billy has one word to say before.
First of all, thank you, of course, Charlie. That was really a great bit of information that you gave us. I think I had on my piece of paper to ask about the Saturday or Sunday appointments, and I'm really glad you clarified that. Also, just transitioning to Fred, I wanted to first ask Fred if he paid my friend Tony more than $39,000 when he came to town. You don't have to answer that right away.
Yeah, okay. Actually, I don't remember.
That's okay.
$39,001, yeah.
Yeah. I also wanted to mention that look, when I came to town, I knew all these guys. They were were legends. Mickey, Charlie, Fred. Fred, in one way, is one of the best Maimonides members we've ever had, because he's like a country club player who pays his dues but doesn't use the golf course. Fred has been paying his dues and not eating any of the locks over the years. We prefer to see him because he's a really terrific person, but I just wanted to mention that about Fred. And also, in addition to his stellar GI career, which is ongoing, I think Fred may be still the single best tennis player in the GI community. And I'm still afraid to have that match with Fred. So
Well, thank you.
that's by way of introduction. I just wanted to say that before Fred spoke.
Well, thank you. Thank you for the honor of coming here and speaking to everybody, honoring Mickey Ufberg as a family man, as a gastroenterologist. And it's my pleasure to speak. And Charlie, those words were very nice. You had also a good review of the old days in medicine. I might add that in those days, we cleaned our soaps with just soap and water. None of the cleaning stuff that we use now or are required to use now. So I was asked to give a talk about gastroesophageal reflux disease. And I think Aaron is trying to get my slides up right now. But basically, I have to say that most of these slides came from the Lehigh. I'm chairman of the, or co-chairman of the Gerd, Gastroesophageal Reflux Committee group of Lehigh Valley. And it's a combined Gerd committee presenting various cases. And usually it's cases that we're not sure what to make of. And the surgeons are on it, the GI people are on it. We have the fellows, so it's a lot of teaching attached to it. And so I have to give credit to for a lot of these slides to them. So we're just waiting for Aaron to. Can
you see the slides?
It just says now on my screen has started screen sharing.
All right,
everybody else. Now we see the face of Bill.
All right, let me try again. Does that work?
No.
All right, give me 1 second.
Aaron and I practiced before everybody got on too. Yep, that's it. Very good. All right, so as I said, our topic today is what is gastroesophageal reflux disease? And it is actually, over the years, the definition and has changed somewhat, or let's put it this way, the symptoms attached to it has certainly changed. Okay, next slide, Aaron. Okay, so reflux occurs when the contents of the stomach flows back up into the esophagus. And the big change over the many years, it's not just acid reflux. It could be reflux of food material and also bile that sometimes retrogrades from the duodenum back up into the stomach. Okay, next, please. So heartburn is the most common symptom and I think we have a slide coming up. About 10 to 30% of people in our country have heartburn at least once a week. I would say that unfortunately, with the increase in weight in our country, obesity in our country, that has gone up, and I'll explain a little bit more later on. People complaining, describing a burning sensation in the mid-chest. So that's the classic heartburn. But there are many other symptoms. Next slide, please. Okay, so sore throat, belching, regurgitation, and that again, when people feel regurgitation, it doesn't always have to be acid. Most of the time it is, but it can be non-acid stuff. Hoarseness, change in the voice, chest pain, chronic cough, exacerbation of asthma, bloating sensation, a globus feeling with something they feel that's in their neck, and dental erosions. Now, some of these things, don't yeah, that one. No, go back to the 2 slides, I think now. Yeah. Some of these symptoms that I've listed, they're relatively new. When I say relatively new, I'm just going to rough it about 15 years, maybe 20 years in the expression laryngeal reflux disease, laryngeal reflux. And basically it's where there are people who can have, besides heartburn and maybe not even heartburn, will complain of sore throat, will complain of sinus issues, will complain of, the dentist says, you have horrible dental erosions, some of the globus feeling. And we call it LPR, laryngeal pharyngeal reflux. When it first came out, I would say, that what happened was we would get referrals, obviously, from ENT, that, I'm being a little bit kidding and facetious, about it, but everybody who had a sore throat, chronic sore throat, everybody who had chronic sinus issue was due to GERD. And ultimately and we'll get into one of those two slides, we then, when I'm saying the gastroesophageal reflux people nationally developed a pH probe where we actually put a probe down into the esophagus and measure how much acid really is coming back up. We also have a probe now that measures acid and non-acid reflux. And what we found basically is the people who have LPR, roughly about 50% do in fact is caused from reflux. 50% it may be a sinus issue or something non-GERD related. Okay, now Aaron, next slide, please. Okay, so complications of untreated GERD. First is esophagitis. Now, many times, actually, people can complain of esophageal or heartburn, I should say, and some of the symptoms. We look down and the esophagus looks normal. Going the other way, when we look down for other reasons into somebody's stomach and duodenum, we pass the esophagus, they can have inflammation in the esophagus. So the symptomatology is not always one-to-one. People can have esophageal ulcers. We only know about it because they're bleeding from it, and we look down because of the bleeding. On the other hand, people can have a grossly normal mucosa and they have symptoms. But esophagitis is obviously one of the obvious complications. Stricturing. As a result of the inflammation, there's some scarring that occurs, and the scarring in the esophagus tends to narrow in a circumferential way, and therefore, food can stick. And they feel they need to swallow it down. And it's one of the causes, and Charlie, I'm sure knows as well I do, at nighttime emergency where we have to go in because there's a food bowl stuck in the esophagus. Barrett's esophagus, precancerous changes, about 5 to 10% of people because of genetics first, and then they have reflux, develop a Barrett's esophagus, and those people have to be monitored. Now it's every 3 years or so with biopsies to see if the changes of Barrett's are not progressing to a more cancerous look. And then esophageal cancer. The Barrett's esophagus basically can develop into unchecked adenocarcinoma of the esophagus, the esophageal cancers. There are other esophageal cancers that occur, squamous cell, that is really not GERD related. Okay, next slide. How common? Next, please. Okay, as I said 10 to 30, but here it says 20 to 40%. Over 9 million primary care visits are attributed. The most common related outpatient diagnosis that the GI people find. Next, please. Okay, who gets reflux? Everyone has some reflux. Infrequent asymptomatic reflux does not require treatment. You should seek treatment if symptoms become more frequent or severe. Next, please. Okay, risk factors for reflux. Obesity, as I mentioned to you before, we're seeing more reflux probably because of obesity. And it's not just because when you start to gain weight, you're eating more fatty foods that can have an effect on the lower esophageal sphincter, but it's actually a pressure effect. Pregnancy actually is not so much a pressure effect, but it's a hormonal effect on the lower esophageal sphincter. Connective tissue disorders cause more of a motility disturbance of the esophagus, and we're not going to get into that today, but people who have scleroderma, Crestis syndrome, Raynaud's can have issues with reflux. And then delayed stomach emptying that we see, it's more commonly seen in diabetics. And it's like a nerve damage to the stomach, just like diabetics can have nerve injury in their peripheral extremities. And then a hiatal hernia, which is a major issue, cause of reflux. If you take 100 people, 50% of basically people who have a hiatal hernia get reflux. Only 10% of people who don't have a hiatal hernia get reflux. So you're more likely to get reflux as a result of a hiatal hernia because of its effect on the lower esophageal sphincter. Next. The fact is cigarette smoking, nicotine, that relaxes the sphincter. We're going to have an anatomical picture in a minute. Alcohol, eating fatty foods or fried foods, that again affects the lower esophageal sphincter. Eating large meals at night, especially lying down, gravity's not helping you. There's an increased pressure in your stomach. It's either going to go downstream, but if you have a weak muscle between the esophagus and stomach, it'll go upstream. Next. Okay, anatomy and physiology, just quickly. Okay, so food passes down the esophagus through the lower esophageal sphincter and into the stomach. Next. Once food is in the esophagus, peristalsis propels food down the esophagus with an organized muscular contraction. So one of the issues is people with connective tissue disorders, the motility of the esophagus is not normal, so you don't have a progressive waves. And in, for example, scleroderma, it affects the lower esophageal sphincter that stays open. So not only do people have swallowing issues where food is sticking because of the contractions, but they have reflux back up because the sphincter is relaxed. Those are some of the issues that people can have. Next. Okay, let's talk about the lower esophageal sphincter, which was felt to be the predominant thing that is causing reflux. Things can influence that. We mentioned some of the foods and things above. So it functions as a one-way valve, or should function as a one-way valve. Prevents stomach contents from refluxing into the esophagus. The function of the sphincter is based upon the muscles of the esophagus, the nerves, and surrounding tissues. The lower esophageal sphincter should be below the diaphragm. That's the muscle that separates the chest and the abdomen. And basically, as I explained to patients, when the esophagus goes through the diaphragm, then in utero, there's putty put around that to close that defect in the diaphragm, which is a muscle. And gradually, in time, that putty can get loosened and get old, if you will. And all of a sudden, there's more of an opening. Some of the stomach rises above it. I sometimes describe it as if you ever see in your air conditioner outside when the piping comes through your building and this putty, your home, this putty put around the connection to the outside air conditioner. And sometimes you'll see if your house is getting older, there's putty there. They have to put new putty in to fill it up. Okay, next, please. Okay, the stomach receives food from the esophagus. The stomach secretes the acid enzymes, digest it. The muscles contract, and this is not the topic for today, but it's not as easy to say like with this heart. There's one spark from one area of the heart that causes the contraction of the rest of the heart. The stomach has multiple areas that control the emptying, and regions of the stomach include the cardia, which is right below the LES, the body, fundus, and pylorus, which are all shown here with the arrows. Next. Next, Aaron. Okay, so I have reflux. What went wrong? Okay, oftentimes in reflux, the LES, the one-way valve, fails. I kind of talked about that, and it's commonly associated with a Heidel hernia. I think we can go to the next one. So the Heidel hernia, the different types, but as you can see in the picture on the right, a part of the stomach has gone above, the diaphragm. That putty is loosened too much, and the opening is too wide, and some of the stomach can go above it. And then when the lower esophageal sphincter is above the the diaphragm, then it doesn't function as well. Okay, next. This is a view endoscopically where this view of the valve of the stomach, the valve should be in contact with the scope and like this. And next picture. Okay, these are 4 different types of a Heidel hernia. The type 2 and 3 are much more problematic in that most of the time you should go to surgery, partially besides the symptomatology, but also if you can see, there could be a kinking and you can get the low blood flow into that hernia sac and cause ischemic and changes where there's no lack of blood supply. Many people have a small Heidel hernia. We don't always, if they're asymptomatic or they are controlled on medications, we don't necessarily have to do anything. Next, please. Okay, treatment options, lifestyle modification, which is helpful, but it's at times, in our society, fast foods, people wanting to, enjoy going out, although not so much during the COVID era, but going out for dinner, having, a glass of wine, and they eat late, they lie down at night, the stomach hasn't emptied, etc. So sometimes it's very difficult. Medical management we'll go through quickly, procedures to restore anatomy, and this is some of the newer things, especially that our Gerd committee looks at. Okay, next. Okay, so lifestyle modification, avoid eating large meals, avoid eating before going to bed at least 3 to 4 hours, avoid caffeine. It's obviously coffee, tea, alcohol, and chocolate. Sleep with head elevated, which is sometimes tough. And just putting pillows is not enough. It should be almost like a wedge there, because if you put pillows up and scrunch up your stomach, you're actually putting increased pressure in the abdomen to push things up and lose weight. Next. So lifestyle modifications work for many, but it depends on how bad the reflux is. Okay. Next. Okay, so this initially, antacids still work. They only last for 20 minutes, neutralizing the acid in the stomach. It obviously doesn't help if somebody has non-acid reflux bile, so to speak. My dad had an ulcer, I remember, in 1960, before we had the H2 blockers and proton pump inhibitors, and he used to guzzle down my Lanta. Okay. Then we developed H2 blockers came about in the 70s. It was actually during my fellowship years, and it blocks stomach signal to the stomach to produce acid. It works roughly about 80% to cut down the acid. And then the new generation proton pump inhibitors, which is not only prescription, but you can get over the counter. They only recommend it for 14 days because they don't want you to hide more significant symptoms that could progress. And we'll talk about that in a minute, because that's the one that has had a bad press about 5-10 years ago and is not totally recovered. Next slide, please. Okay, so PPIs work by shutting off the acid pump in the stomach, has become the mainstay of medical treatment of GERD, can be effective treatment option for intermediate symptoms of GERD, the right choice for many patients. Is available over the counter, but again, prescription usually is cheaper ultimately for long-term use. And then in the red square, concern has been raised regarding the safety of long-term PPI use. Next, please. The bullet points there are the ones that have been circled, circulated around for the last 5 to 10 years. I would tell you just about everyone, or almost everyone, I'll separate out the kidney for a second, but all of them have been shown not to be the case. The classic is that was the first one that came out, was the dementia, and that was actually looked at in VA patients, and they separated out 2 groups of patients, one that was on a PPI, one that was not. They did not separate out if that group had equal number of diabetics, equal number of hypertensive patients, equal number of patients who may have had a stroke before, hypertension, etc. and it turned out to be a bogus study. There was actually a study in Finland, 30,000 people, and shown not to be the case. Okay, all the others, again, PPI interaction with Plavix, omeprazole has been the major one, and you could just switch to another category. All the other ones have been shown not to be significant. Our society a few years ago said to recheck a vitamin B12 level, of magnesium, every year, and then went to 5 years, and now they don't even recommend it. Osteoporosis was a big factor, and now it's felt that there's no increase in bone fractures. So, it's unfortunate, but what happens is, the headlines to the first article, and then the retractions are in the back page of the newspaper, so to speak. With kidney disease, we still, there's no real major association with the progression, but what we do a lot of times with the nephrologist, if somebody has kidney disease, because we don't know the real effect on the kidney, we put them on an H2 blocker. And so that's the only one that is some significant, perhaps significance, we don't know. Next, please. Okay, PPIs oftentimes are ineffective in addressing mechanical symptoms, and we kind of talked about that a little bit. And these are the listed of the more of the LPR, laryngeal pharyngeal reflux. Next. Okay, procedures that restore anatomy can effectively treat the mechanical symptoms of GERD, can alleviate symptoms without the need for long-term treatment. Require diagnostic testing in advance of procedures. And there are basically three options. Now, let me just say to you, with somewhat of a skewed eye, and I'm sure Charlie remembers over the years, we've had multiple attempts. First, let me start. The Fundoplication has been around for years. Initially, it was an open fundoplication, and then now it's a laparoscopic through the belly button. And the numbers show that in most cases it's successful, but about 60 and now 60%, the initial article says 60% of people after 5 years have to be on some kind of acid reducing medicine too. Then there was another study said if you go to a surgeon has done multiple, it may be you're good, for only 20% that needs some extra care later on down the line. Now, the other two are more recent, and going back to what I said about Charlie, we remember we used to have the angel check prosthesis. We've had a whole bunch of other techniques to try to replace, easier than the fundoplication, to replace it, and they've been withdrawn. And that's why I said it's in a skewed mind. The next two, one of my partners actually does the Tiff, and then the Lynx, which is the magnetic sphincter. I think that we need, even though the 5-year studies look good, I'm still, a little, jinxed by the previous attempts in the past to replace the fundoplication. Although I have occasionally sent people for those two, or the last two. All right, next, please. Okay, so what do we have to do before we even think of going to a surgical technique to change the structure, so to speak? One is Banometry. Remember I said about the esophagus muscles should contract, progressive peristaltic waves. So we want to see, because if we're going to tighten that lower esophageal sphincter, you don't want to have a weak contraction more proximal to it, because the food won't go down. Okay, we want to make sure that the lower esophageal sphincter is, that in fact it is on the weaker side. The pH studies that I mentioned before, there's two. One is we put a pH probe down endoscopically, attaches to the esophagus and measures acid. That's the easier one. The next one, which is really the gold standard, is we put a 24-hour catheter down. People go home with it, and the catheter measures acid and non-acid. That's really more definitive, because remember I said to you, not all reflux symptoms are due to acid. And then we also sometimes look with an esophagram. There's a new one that we call a marshmallow study, and it's a timed esophagram. We kind of look at how the contractile wave is. Okay, next. All right, the fundoplication, again, that's been the standard bearer. I think it's been since the late 60s. Basically, it's they tighten the sphincter by wrapping a part of the fundus, the top portion of the stomach, around what we would call the gastroesophageal junction, which is where the lower esophageal sphincter is. The problem is that the sutures can break down. A problem also is that there can be a gas bloat syndrome, meaning that although it allows food to go through, if you have too much air in your stomach, you have problems with belching and actually sometimes vomiting. And that's the one that I say with sutures sometimes break down 60%, or it goes down to lower. It may be in a surgeon's hands that does it a lot more. But there's enough people that still occasionally will need acid suppressing medicine after the fundoplication. Next, please. Okay, the next is the links. Now I'm going to go back to the angel check prosthesis, and that was sort of something that just slips on around the stomach at the junction between the esophagus and stomach. That was more of a collar attached to it. I'm not sure now what it was made of, but it loosened up too much, and that fell by the wayside. They now have a magnetic lower esophageal sphincter augmentation called, it's a trademark links, but basically they're nickel circular beads, and they're magnetized. Now, obviously, we can't put it down for people who are allergic to nickel. Next, please. I don't know if that shows anything. Yeah. So what happens is the links, the magnet is tight enough to prevent acid or non-acid stuff from coming back up, but it's not strong enough to stop food from going downstream. It can be an outpatient procedure. It's most of the time MRI compatible, and it has been successful in 5, now almost 10-year studies. Is still in a lot of insurance companies felt to be experimental. So for insurance reasons, it's not been done as much. There are some thought long-term, if somebody is a 30-year-old, doesn't want to be on PPIs for long-term, you have a foreign body there. Are you going to have issues? Are you going to have issues with autoimmune because of a foreign body, autoimmune problems? And then also there could be scarring there. So if all of a sudden the links doesn't work, it's much, much harder surgically to take it down, take it out. All right, next. That's basically the way it looks. Okay. All right, next. That's the way, if you see the first one, the Heidel hernia look that we showed before, and then the tightening of that gastroesophageal junction or the lower esophageal sphincter muscle. All right, next. This is showing some of the studies that there is benefit. There are several studies. As you can see, most of these are the 5-year studies that are, the longest. Next. Okay, the Tiff, transoral incisionless fundoplication. If, when patients ask me about it, because one of my partners does it, 2 of my partners actually do it, I said, I think this will be the state of the art in 5, 10, 15 years. And, even though my partners do it for certain patients, and I'm not saying they're wrong at all, but I think we're into the 2nd, 3rd generation, and it's going to be perfected, I believe. And the reason I think it's going to be the state of the art and the gold standard is because it's endoscopically done. But basically, you could see. Let me just go to the next slide. And it shows you the technique. I think it's endoscopic technique. Go to the next, Aaron. Yeah, and you could see you put the scope down and you basically pull down some of the extra tissue. It's sort of like doing the fundoplication, but it's doing it endoscopically. And then on the step 3, 3rd slide on the right, you could see the sutures. And it actually works pretty good. You can't, if you have a Heidel hernia greater than 2, you can't do it. Most of the time, they just like it be 1 or so to do it. A large Heidel hernia, you have to have the hernia repair. I do, again, think that this down the road, 5, 10 years, is going to be the way we're going to be going. Next, please. All right, okay, next. And who may not be a candidate? Obese patients, patient greater Heidel hernia, as I mentioned, 2 centimeters, people who have limited neck mobility, and there are various obstructive things in the esophagus, severe esophagitis, you first want to treat it because you're going down and you're going to be, disrupting some of the esophagus where the Tiff is going to be needing to be sutured. And next. And basically, this is kind of a review from mild to severe, early disease, no anatomical correction. We use the pharmacologics. And then when it's more severe, we start to think of, the newer techniques. And this is what I have to go through, or not have to, but, patients will ask me what my opinion is. And a lot depends, patients who are totally stable on a proton pump inhibitor, I basically leave them alone unless they have a huge Heidel hernia where that may be troublesome. It's only ones I'm having issues, and then I work them up to see if it's acid, to confirm that it's acid, to confirm that maybe it's non-acid, bile coming back up. And sometimes it's hard decisions, and that's why, at least our committee, we present more complicated cases of what we should or shouldn't do. Does anybody have any questions? Hopefully I covered things that are interested to everybody, the medical people and non-medical people.
Hi, Fred. Hi, it's Charlie.
Yeah.
It's interesting. I've tried to look and see if it's even known what % of reflux patients are alkaline. How rare or uncommon is it? It's the first thing. And secondly, as a separate issue, for a few years, I biopsy distal esophagus to see if microscopic esophagitis is present. Now there's an article about 3 months ago saying that it's sort of irrelevant, that whether or not there are histologic changes doesn't count for much. So maybe it doesn't bear relevance to what the next decision is.
Yeah, I agree. First, relative to the biopsy, I don't even biopsy the distal esophagus, obviously something grossly there, or I'm thinking of some other entity, eosinophilic esophagitis, which is another topic. So I don't even biopsy the distal esophagus. And I tell people what we see and what they feel are not always one-to-one. If there is a need for decision-making, is this really reflux? Then I go to usually the Bravo off or the pH probe for the off PPI, just to see is there acid? Is it functional? I didn't mention, these slides didn't have that there can be a functional component to some patients, and you have to, or hypersensitivity I didn't get into, but some people have the normal amount of acid reflux that everybody that has, but they feel it more. So should they go for surgery? Or we have now some medications, amitriptyline being one of them, that is, it's a low dose. It's not in a depressive as an antidepressive medication, but it cuts down the brain esophagus pathway, and it cuts down the hypersensitivity. So that certainly is relative to what you said about the numbers of alkaline and acid. I don't think there's any good study, because it's who you're picking, for it. And there's not, how do you pick all comers, but I've never seen a good study.
Mm-hmm. Thanks. Mm-hmm.
I have one question for the Silver Fox.
Yes.
There's a lot of overlap sometimes between, GI and cardiology and all these kind of vague symptoms. And I heard in the past, and I want to make sure I'm not wrong, is that a lot of people take these PPIs improperly, that you have to take it, 30 or 45 minutes before you eat something, kind of like, when you use Roundup, if it hasn't rained and there's no weed growing, if it's not going to be peaked at the time that there's acid production, it's meaningless. And I don't know if it's anecdotal, but sometimes I tell people that, and they really seem to be doing better. But am I full of crap? Is that really something, or?
No, it is, but something. Meaning that, well, first let me just go to the H2 blockers, the Pepsid, the Tagamet, those medications. We usually do it like once or twice a day, unrelated to food, okay? Because it cuts down the pathway, the neurologic and protein pathway that stimulates the acid, okay? The proton pump inhibitors, what happens is, the reason we think it works best, that doesn't mean it doesn't work if you take it after a meal. It just doesn't cut nearly as much acid. What happens is it gets into the bloodstream. So you take it a half hour. I always tell people to take it, a half hour when they get up to pee in the morning, to take it. And of course, some of the older people say, well, which time when I pee? Is it 3 o'clock, 4 o'clock? I say, it's the last time before you decide to get up out of bed and take it. So it gets into the bloodstream. And what happens is food, then you eat food a half hour later. And the proton pumps then show themselves. If you don't eat, the pumps simplistically are hiding. So you're not cutting down all of the pumps. So a half hour later, you cut down close to 90% of the 85, 90% of the pumps. And then what happens is over every hour, basically, the body starts to regenerate new pumps. And by 24 hours, you have enough pumps there that you got to knock them out again. Now, sometimes people produce the pumps on an hourly basis, faster. So what happens is after 12 hours, basically, at dinner time, they have enough pumps that they can feel symptoms. So the second, if they still get symptomatology, okay, I cut the pumps down also before a half hour before supper. Now, it's one thing also to say, people say, well, I have mostly my heartburn symptoms after dinner. So I sometimes hear from, primary doctors say, okay, take it before dinner. More pumps show themselves for whatever reason, hormonally or whatever, show themselves in the morning more than at dinner time. So you're really going to cut down more of the, 80% of the 100 pumps before dinner. You're only going to cut down 80% of the 50 pumps that are there. So that's why first half hour before breakfast, half hour before supper. And I tell patients, listen, if you forget it, sometimes everybody's going to forget the medications, then just take it whenever. And just one other thing to add with Dexilant, which I'm on, partly because I don't have to worry about the insurance because I get the samples, but because a lot of insurances don't cover it. Dexilant came out. It's really Nexium, but it you could take it almost any time, but just for argument's sake, you take it a half hour before supper. And then there's a slow release. So as the proton pumps start to regenerate, the slow release knocks them out over the 24-hour period. Unfortunately, a lot of insurances don't cover it. And that's the big gun that we go to. Okay.
Right,
Oh, and then if I just ask one more thing, mention to you non-cardiac, remember that, we see a lot of non-cardiac chest pain. So if somebody comes to me with chest pain, I always want cardiac, refer them back to the cardiologist, say you clear it. But I just want to remind everybody that there can be non-cardiac, non-esophageal chest pain. It could be chest wall too.
I have a comment, Bill.
Sam, you and then Carol next, or if you want to let Carol go first, the daughter and the father have questions, so you guys decide who gets to go first.
It's Bob Wilson. I have two questions. Are there multiple Tiff products out there, and is one any different than the other?
It's a good question. I don't know the answer. I believe there's only one major one. I'm sure other companies are coming out. I know the one that my partner uses, they've done some tweaking on that. So we always, when he does it, there's always the, company rep there and et cetera. It's a good question. I don't know the specifics, but I'm pretty sure if there are multiple companies, there's one major like Olympus, compared for our endoscopes compared to some of the other companies that make endoscopes.
My second question is who and who does not cover this procedure insurance-wise?
I can't give you specifics because a lot of it is, if I say it's the blues, it depends which product of the blues they have.
Right.
Because it'd be 10 or 20. So all of these, when they cut, my office, they have people that, actually, go to see if it's
right.
And sometimes some of the insurances will say, well, they failed the PPIs, and that kind of stuff. So it's very hard. And again, I know through, the surgeons at the links that is basically, pure surgical, they have a lot of problems, for insurance companies.
Nice talk. Thank you very much.
Thank you.
Let Carol ask, and then Sam Bob, and then Mark Burson.
Thanks. Hi. We certainly see a lot of this in primary care, so any updates are always appreciated. I have a question about caraphate, which we hadn't seen for a long time, and now I seem to see kind of resurfacing in some of my patients that have come from GI or from inpatient. Is there any use for caraphate, and when and if do you still use it?
Yeah, caraphate basically, binds to inflamed areas. Okay, it increases PGE production, and therefore that's a healing process. So I only give it I only give it for esophageal problems. People have esophageal erosions, and they're very symptomatic. Despite me cutting down the PPI, the acid with the PPI, they still could be, it's like an open sore. So I sometimes tell people, listen, with a PPI, we cut the fire out, but you still have that sore from the fire that was there yesterday. Okay, so caraphate can bind it, and a lot of times they feel better. The problem with the caraphate for the esophagus is it's a suspension, and the insurances don't want to pay. It's like I one time gave it to my daughter, who I think she swallowed a bone or something, and it went down, but she felt a soreness. So I called in a prescription for caraphate, and then she called me back. She said, "Dad, what kind of doctor are you?" It cost me $600 for a week's worth. So caraphate, number one, binds. Now, do we use caraphate for erosions in the stomach? Yes, but again, that you can use the pill. But I don't use it long term. If I ever use it, it's mostly for the esophagus, which I have problems with because the insurance don't cover it. If I do, say, for example, a band of varix, I produce an ulcer once the varix is clotted, and there's an ulcer there, so I'll use it for a week. So I only use it, part-time, if you will.
Sam?
So I graduated in 1963 at the University of Cape Town, where we did the first heart transplant. We used to have patients with bleeding ulcers, and we used to put them to bed rest, and we kept them in hospital for many, many days. But eventually we did what was called a vagotomy and a pyloroplasty to cut down on the acid. And I assisted at multiple of those surgeries. The day that Tagamet came out, I have never had another patient with a bleeding ulcer go to surgery. These are remarkable drugs. And when I practiced, I usually tried to prescribe the cheapest. And that was Cimetidine, But these are remarkable drugs.
No, I totally agree. We almost, even the resident of general surgery, I don't think they've almost ever do ulcer surgery like, you saw, I saw, Charlie saw in the past in our training. So they never see it because they are remarkable drugs. I mean, we obviously see ulcers that bleed, but even that, rather than go to surgery, we have endoscopic approaches with cautery, with basically staples, endoclips to close them. And then we treat it with the proton pump inhibitors or the cimetidine. Now, proton pump inhibitors cut down more acid than the H2 blockers. And one of the things that people say to me, well, why don't you just go to Tagamet and the others? Why do you go always to the big gun, if you will, the proton pump? And I say, I have no problem with that. We see a skewed population. So we're seeing people who a lot of times will fail the H2 blockers, the Tagamet and the cimetidine, Zantac, et cetera. So we're seeing the people who fail. But there's no problem if people feel well on Pepcid, Tagamet, there's no problem in doing that. Now, one other thing to say is that they did some studies, which I think are very true. People leave the hospital, they're put on either Tagamet, famotidine, Pepcid, or Prilosec, pantoprazole, the PPI, and they're sent out. They're put on in the hospital for protection because of stress-induced ulcers, and then they never get off of it because they go to a nursing home or they go to some facility, and it's continued. And I obviously don't agree with that. Somebody has to follow that and say, why did they put it on to begin with, to say whether they could stop it or not.
We're going to go our last question for Mark Burson, and then Billy is going to close the program.
Hi, thank you. First, I'm an optometrist, so I deal with a lot of people with problems with their ocular anal nerve they're people who typically have a crappy outlook on life. I'm not sure you've heard that one. But question about the frequency of upper endoscopies, EGDs. A patient who has had a Nissen fundoplication years ago and not ready for a Tiff. Do you typically continue with the three with Barrett's and changes in the esophagus, but well managed? Would you typically continue with a 3-year course of EGDs, or do you do more frequent than that?
Yeah. Well, first, that's actually a good question. We don't do, say if somebody has symptoms and they have Barrett's esophagus, okay, a fundoplication, Tiff, links will not reverse a Barrett's esophagus. So the underlying precancerous, mucosa is there. So then the question is, do you do a fundoplication for their symptoms? Okay, if you do, it's purely for symptoms. It's not to stop the Barrett's. Now, the next question is, what causes the progression of a Barrett's? And that's the thing that we don't truly know. We suspect some long-term studies show that with the proton pump inhibitors that we continue sometimes twice a day on patients, you're preventing the irritation of acid, okay? And therefore, as a result of that, you're maybe preventing the progression of the metaplasia of a Barrett's to dysplasia. And then the last, maybe a part of your question is, we still recommend with a Barrett's, it's every 3 years, regardless of whether they have it or not, because you just don't want to take, if you will, that chance. With a fundoplication, a breakdown of the fund, once you have a fundoplication, I'm almost 100%, I can't say this, 99%, I can't say 100%. I don't think you could be a TIF candidate because you've already surged from that fundus, okay? But the answer is, everybody on a Barrett's basically should stay on acid reduction as much as you can with, usually it's PPIs.
Thank you.
Billy?
Well, listen, I really appreciate both of our speakers. That was a great talk, medically informative. Charlie, I really enjoyed you talking about Mickey, and also just reminiscing about what it was like to at least be in medicine in the 80s. And I mean, I had the same kind of running all over the place life that you guys were mentioning. And it's, of course, looking back on it, it sounds so, I don't know, I won't say glamorous, but, it's like looking back at your basic training days from the war, all of a sudden it makes for great stories. But while we were in it, it wasn't that much fun hustling like that. So I'm glad everyone came to listen to this. It was really a special talk from both of you guys. And again, I'm encouraging everyone to reach out to Jerry or Aaron or me if you have any interest in this Israel trip. And anything else you want to tell Aaron about how to pledge, or because I forgot what you told me to say exactly in the chat.
I just want to, I'll thank everybody for coming, and to remind them that if you haven't pledged for your 2022 Maimonides Society, or renew your pledge, that we are going to follow up with everybody with the recording, and that it's very important for us to continue the legacy of Mickey. It requires not only to be committed to the medical profession, but half of his work was done through philanthropy, and a good way to honor his legacy is to ensure that the Maimonides Society continues to be a society of good, not only in medicine, but also to the outside of the Jewish community, which was one of his greatest qualities, the work that he did with the Jewish community. So please make sure that you enter your gift to the community. We raise money to allocate money. They go to our main agencies. And also, if you're interested on the mission to Israel for bikers and for non-bikers, we have 2 separate missions going together And the highlight of the mission is going to be on Thursday or last Thursday in Jerusalem, donating the ambucycle with the Ufberg family there, with all of our missions there, all together in Jerusalem, donating an ambucycle in honor of Mickey and spending Shabbat in Jerusalem. So that doesn't sell you this opportunity. I don't really know what else to say. Thank you, everybody. Thank you to Dr. Brooks for joining us on the phone, and Fred, who hustled to get me the PowerPoint to make sure his presentation was done, and Dr. Billy Markson, who hustled to New York City to be able to do it on video and not just on the phone. So thank you, everybody, and we'll see our next Maimonides call. Thank you, everybody.
Thank you.